when performing the trans-radial cardiac catheterization, one of the most important things is access techniques. We realize that the reasons for failure is due to spasm. So it's important to enter the radial artery with one stick to prevent spasm and hematoma. Another thing that's important is sedation. Pain or any discomfort will cause more radial artery spasm. Spasm can be reduced by intra-arterial antispasmodic agents such as nitroglycerin, verapamil, adenosine, or lidocaine. We have found that just the use of intra-arterial verapamil or nitroglycerin is sufficient. These agents can also be given during the case and even at the end of the case prior to removal of the radial artery sheath. Another thing to consider is anticoagulation, as I mentioned before. Early studies have suggested very high rates of radial artery occlusion or thrombosis. It was felt due to insufficient anticoagulation or trauma, stress to the inner lumen of the radial artery. The newer equipment prevents less of this, prevents this occurring much more often now. And we also use anticoagulation in the form of antiplatelets. Heparin can be given intra-arterial or intravenous. Angiomax can be introduced as an anticoagulant agent. What we find, because of the pain from intra-arterial injection of heparin, we give heparin intravenously, weight-based, ranging from 40 to 60 units per kilogram. Another important thing to realize is puncture site and the position of the wrist. What we try to do is to elevate the wrist, usually using a rolled up towel beneath the wrist to push the artery up. Then a little amount of lidocaine is applied to the access site. And the access site, remember, needs to be 10 to 30 millimeters from the palmar crease. Only a small amount of lidocaine is introduced initially so that you are still able to palpate the radial artery. Once you palpate the radial artery, then puncture is performed using a micropuncture needle. Once you get blood back through the needle, and this blood flow through the needle will not be like blood flow through a Cook needle via transfemoral access. You may just see a little dribble of blood. Once we see blood back, and then you can thread your micropuncture wire. We can use a modified Seldinger technique where you puncture only the top wall of the artery, or we can use a modified Seldinger technique in this slide where both walls of the artery are punctured and then the needle is pulled back into the lumen of the radial artery. Both techniques work equally well. Once the wire is introduced into the radial artery, then we give some more lidocaine, and a little nick is then placed at the origin of the wire before a sheath is introduced into the radial artery. Another technique which may help is as with the femoral access, we find that in older individuals, the artery can become calcified. The artery can roll from one side to another. So we're able to trap the artery using knowledge of the anatomy. As we can see here in this MRI of the wrist, the radial artery lies just above the radius bone. And on either side of the radial artery are two radial veins. So by palpating the radial artery, we're able to compress the veins. We're also able to trap the radial artery against the bone, and this enables us to get access very easily. This is another slide here just to show how the radial artery lies on top of the radius bone. Another technique which is useful, especially if the artery is rolling in the wrist, is to go from a lateral to a medial position in order to cannulate the artery. By going from this lateral to medial position, once more we're trapping the artery against the bone. Once we puncture the artery and we see blood coming back from the needle is then brought back coaxial to the artery, and the wire is threaded in to the lumen. We can use palpation to get access into the radial artery, but we can also use Doppler and ultrasound. There are various Doppler needles available, and ultrasound is something which is very useful. This is a slide which shows radial artery access using ultrasound. And over here, our ultrasound is able to show us the radial artery. With this, we're able to visualize the needle as it goes into the radial artery. We're also able to measure the diameter of the radial artery, and it tells us what sheet size we can put into the lumen of the artery. There are many reasons why we would fail in terms of access. Spasm is the most common thing, but we also have to be aware of radial artery loops. This is fairly rare, only occurs in approximately 1 to 2% of patients. However, even with these types of vascular tortuosities, we can still, there's still techniques we can use to bypass these loops and to correct these loops. Spasm tends to cause a great amount of failure. The slide here shows the radial artery, the inner lumen, and the inner lumen after injection of intra-arterial verapamil. So you can see how much larger the artery becomes. The cocktail that we use here is up to 2.5 milligrams of intra-arterial verapamil given at the time of sheath placement. And we would examine the patient's blood pressure and give up to 2.5 depending on what the blood pressure is. We also have intra-arterial nitroglycerin given in doses of 100 micrograms, which can be given at the same time. Just like heparin, which is given intra-arterial, verapamil can cause burning or stinging within the radial artery, and so needs to be buffered with blood when introducing it into the lumen of the artery. These are the only two antispasmolytics that I use, and I will use them throughout the case, and will use them at the end of the case when the sheath is removed. Now, probably less than 3% of the patients after a transradial catheterization can have some type of occlusive or non-occlusive injury to the radial artery. Again, it's not completely clear as to what causes this occlusion. We do know that there is some intimal hyperplasia of the tissue within the artery. And this intimal hyperplasia occurs in segments, and usually at the site of sheath insertion. So again, very important to use anticoagulation during any type of radial artery case. This is a study from Pancholi who looked at a group of individuals who came back to the cath lab within 1 month after initial procedure. These individuals had a totally occluded radial artery. However, Pancholi showed that he was able to go through this occlusion and perform the procedure again with these individuals. So to have occlusion does not necessarily mean that you can't use that arm again. And this is a slide which shows that hyperplasia that we see in the radial artery in certain individuals, probably less than 3% of individuals now. There are also channels, especially during the first few weeks of this occlusion, where you can bypass these channels or pass through these channels using a micropuncture wire. Now, what is the rest of the world doing? When it comes to patient selection, when it comes to starting a trans-radial cardiac catheterization program in your facility, what is the rest of the world doing? This was a questionnaire that was sent out by Bertrand in 2010. It was sent to hospitals who performed trans-radial catheterization. These were hospitals in 75 countries, approximately 1,100 patients. So this is what the rest of the world is doing. And what we see here is that the rest of the world, the US is in red and the rest of the world is in blue. Most individuals were using the right radial for trans-radial access. Less people were using left radial access. Most people were just using a regular Allen's test, not the modified Allen's test that I was recommended. But it's good to see that a lot of people in the US are using this modified Allen's test with the pulse ox, which I think is the more objective test. More than 90% of these institutions in the rest of the world were doing percutaneous coronary intervention using the trans-radial approach. When you look at the US, basically it was a smaller numbers using the trans-radial approach for percutaneous intervention. Actually, the majority of US institutions were still using the transfemoral approach. When we look at sheath size for trans-radial access, we can see that for most of the world, as well as in the US, most individuals are using 5 or 6 French sheaths. And so most of the procedures, including percutaneous coronary intervention, can be performed by a 6 French sheath. How about engaging the coronary arteries and engaging the left coronary system? Most of the world is using the Judkins left 3.5 for engaging the left coronary system, followed by the JL4. This is very different from the transfemoral approach where we use JL4 most of the time. What it suggests and what our textbooks tell us, that if you are going to engage the left coronary system from the right radial access, the JL catheter should be reduced by half the size. So to engage the left main from the right radial, use a JL 3.5. If you're going to engage the left main from the left radial, use a JL 4. For the right coronary artery, everyone still tends to use and favor the Judkins 4, the JL4. Another thing to consider is the Amplatzer, or the AL. This can be used to engage both the right and the left coronaries. Another thing to keep in mind, there are now also universal catheters which can engage both coronary arteries, which can also be used to enter into the left ventricle. And these universal catheters, which are specific for radial artery catheterization, limit catheter exchanges and therefore help to limit radial artery spasm. What happens when you fail to perform a cardiac catheterization via the trans-radial approach, whether it be due to spasm or tortuosity? Most people still in Europe and the US will just cross over to the femoral side. I think it's important to now also consider crossing over to the other hand, the other wrist. This will be important as your program, as your skills develop. What about occlusion or loss of the radial artery? As you can see here, we see that there's documentation of less than 5% occlusion or loss of the radial artery. However, if a modified Allen's test has been done prior to the procedure, we know that the wrist or the hands are not at risk, and a lot of times we can have recanalization of that radial artery, or can even perform procedure in that artery as long as we get access more proximal to the site of occlusion. So to finally summarize, when it comes to beginning a trans-radial program, when it comes to selecting patients, initially when starting this program, I would recommend that these procedures be performed on bigger, taller individuals. These individuals tend to have larger, more palpable radial arteries. It's important to try to consider performing diagnostic procedures first. So if you have an individual who you suspect the stress test is probably incorrect, they may have normal arteries, these may be the individuals to start your transradial procedure on before you start doing them on the elderly diabetic patient who is very likely to have significant coronary artery disease. These type of procedures are much more difficult in smaller individuals. These individuals have radial arteries which are much more difficult to cannulate, much more difficult to palpate. It's important to perform an Allen's test on these individuals so that we can be sure that they have good collateral flow to their fingers. I recommend doing a modified Allen's test with a pulse ox and to use the Barbeau classification. Also in the beginning, because of the lack of subclavian artery tortuosity on the left side, it may be recommended to use the left transradial access before using the right transradial access. As people become better, as your skills improve, I don't think it makes any difference whether you use the right or the left radial artery. It's important to reduce pain and anxiety. Pain and anxiety lead to radial artery spasm, so it's important to control anxiety, important to control pain in any way. Elderly patients, diabetic patients, and patients who may have peripheral artery disease may tend to have extensive atheroma. They may have smaller vessels, may have more vessel tortuosity, and so this may be seen in the upper extremities. These are individuals perhaps to stay away from initially until the skills of the cath lab and the individual are improved upon. And also consider preparing the groin site, preparing the femoral artery access site in case you initially fail with transradial access. Keep in mind to consider access with the other wrist as well.